I'm John Sheppard, Norfolk, Virginia Eye Consultants, and now a partner in Cincinnati Vision Partners. I'm a cornea specialist. I do a lot of ocular surface disease. I do inflammatory disease. I see a lot of patients with uveitis. Do a lot of surgeries in patients who have chronic inflammatory ocular surface or intracameral disease. My job is to control inflammation, and without excellent diversified anti-inflammatory therapies, my patients generally have very poor outcomes. At this point, I don't use the dehydrated, denatured amniotic membranes. In the past, I've been frustrated because they decenter under the contact lens very quickly. They dissolve very quickly, or I don't know where they went. And I've had some scarring and melting despite that particular therapy. So we use cryopreserved amniotic membrane daily in the practice. And we use it weekly in the operating room. And this technology is better, safer, it's easier to manipulate, it lasts longer, and the outcomes are predictable. The scientific literature backing this technology is magnificent, extensive, peer-reviewed, and answers so many of the questions that concern me. Comparison to a therapeutic plastic bandage contact lens, for example, and analysis of the return of corneal nociceptor nerves with the treatment of a cryopreserved amniotic membrane and the persistence after removal of these beneficial effects. So not only is there an acute effect in the immediate therapeutic time in which that lens is on the eye, but that effect persists with proper low-dose maintenance therapy for ocular surface disease. I find that very exciting. You're actually changing the phenotype of the cornea, the epithelium, the stem cells, and the corneal nerves. The reappearance of corneal nerves in patients with neurotrophic keratitis after cryopreserved amniotic membrane therapy emphasizes to us the regenerative effect of this particular intervention. And the HCHA PTX3 is a unique compound available only in this particular product because freezing and drying out amniotic membrane removes this vital component, but cryopreservation preserves it in its full biologic activity. So with this unique substance that is found only in activated fetal tissues and therefore available to the corneal and ophthalmic surgeon through PROKERA and AmnioGraft, we are able to provide a substance that is highly biologically active, regenerative, anti-inflammatory, and allows us something that we have available to us nowhere else. I had a wow moment the first time I used all of them, and we talked about two of those in terms of a patient with an ulcer for the sutured AmnioGraft, in terms of protecting glaucoma valves with the AmnioGuard. In terms of PROKERA, we had several wow moments as we moved from indication to indication. The first ulcer, the first viral ulcer, the first fungal ulcer, the first desmetocele in a patient with bad rheumatologic disease that didn't perforate even though I thought that it would. And then of course the first person with very bad diffuse 4+, almost confluent punctate keratopathy with bad diabetic neurotrophic keratitis, responsive to nothing and on a lot of different preservative-free drops. A week of the PROKERA, the staining was almost gone. And I see that time and again in patients with Sjogren's, but especially in the diabetic neurotrophic keratitis